And I hope everyone can hear me okay. If no one stops me in my tracks, I'll assume that people can hear me fine. But it's a real pleasure to have the opportunity to speak with you all today. Thank you for inviting me, but more importantly, thank you for really focusing on such an important topic, which is how physicians are attending to patients, not in terms of the physical care, but how they're attending to patients psychologically, and how we can use natural language processing and a range of other techniques to understand dynamics such as bias that occurs naturally in physician and patient care records. So as a social scientist, what I want to do, at least in the beginning of this talk, is to give you a little bit of grounding of how I approach the world of trying to understand psychological processes and social processes through language patterns, and then walk you through some of the work that I've done, published just about 6 months ago in PNAS Nexus, which is sort of the offshoot of the Proceedings of the National Academy of Sciences journal. But let's begin there. So how does one approach the world if we try to understand what's going on with people psychologically through the lens of language patterns? I draw on a lot of the work from a really renowned psychologist, Jamie Pennebaker at UT Austin, where in order to understand how language can relate to psychological processes, something psychological must happen in a person's life that changes how they communicate. And we can pick up on that specific communication change with specific language patterns. So let me give you an example, one that might actually be relevant to a lot of the context that we're talking about today. So most individuals who might be interested in psychological well-being, one aspect of psychological well-being is depression. Now, a lot of clinical psychology research and a range of other disciplines have suggested those who are depressive, they tend to focus inward. They focus on the self. They tend to have a more inward disposition or a more immediate disposition compared to those who are non-depressive. And now this immediacy can actually change how people are communicating. So I do see that there is a hand, so I'm happy to field questions in the middle of the talk or at the end. So if there is a hand here, feel free to go ahead.
Dr. Markowitz, we'll just
Yes.
hold questions till the end.
Oh, no problem. That sounds great. I saw a hand there, so I want to make sure that everyone was seen, but that's totally fine. So now we can identify in a more immediate disposition through self-references. So words such as I, me, or my, they tend to indicate depressive compared to non-depressive individuals. So for example, work that I've done on depression and suicidality, especially when we're looking at natural language processing, you look at depressive poets and suicidal poets, depressive musicians, suicidal musicians, they tend to have an increase in self-references in their lyrics and their poems compared to those who are non-depressive. All what we're trying to do here is we're trying to infer psychological effects about people through their word patterns. And critically, language patterns are markers of one's focus and their attention. So for example, an increased rate of negative emotion, for example, doesn't mean that someone may have felt that internally, but they're focusing more on the negative aspects of one's experience compared to someone who uses fewer negative emotion terms. So now sort of with that grounding, we can take that sort of perspective and try to understand how there are disparities in how physicians attend to patients differently based on the demographic makeup of particular patients. Now, a lot of this work has really stemmed from really foundational work published in the New England Journal of Medicine and a variety of other outlets where, for example, a really landmark study by Schulman et al. In 1997 had physicians at a large medical conference. They were randomly assigned an experiment to look at case files for a bunch of different fictitious patients, and you'll see that the patients here, they differ based on a range of different demographic traits. And then they had to essentially make a recommendation based on the generally equivalent case files for all of these different patients. Would you, or what's the probability you would recommend a relatively routine procedure such as cardiac catheterization? So how well is the heart pumping, essentially? And I believe that's right, but I'm sure there are others in the room who would be able to tell me if I'm overstating or understating what cardiac catheterization is. And you can see here the probability of referring people for cardiac catheterization was not equal across different demographic groups. So there's a disparity in how people are recommending a fairly, again, routine test. So females were less likely to be referred, Black individuals were less likely to be referred, and Black females in particular were the most undermined group, where, again, a fairly routine and ordinary test was underprescribed for typically minority groups. Now, when we look at just an incidence of gender disparities and how it might appear in medicine, there's a range of evidence that suggests in terms of attending to patients' emotions, there's a difference in how males versus females or women versus men are actually treated in terms of thinking about their care. So, for example, in order to figure out how people should deal with shoulder pain, females were more likely to be recommended psychotherapy, so having to deal with their emotions, than males. And again, all else being equal, you should not be recommending different forms of treatment based on gender unless there is some disparity in how physicians are essentially thinking and feeling about those particular patients. In a really wonderful review paper, all this to say, men are perceived as brave and courageous quite often when it comes to how they're dealing with pain and medical issues. And for the same types of diagnoses and experiences, women are often viewed as just being overly emotional or exaggerating their experience. So this leads to, at the language level, we should find these disparities. So one of the first predictions here is that physicians are going to focus more on the emotions and the emotional experiences of women compared to men. And again, this is at the language level, not just thinking about what they're recommending in terms of their care, but we should see that the attention of physicians is different when they're attending to women compared to men in terms of patients. Now, an interesting sort of complementary hypothesis to this first one is that by attending to more emotions of women compared to men, there's less attention that physicians are going to be able to have on other critical aspects of one's care. So complementary to hypothesis one, hypothesis two is predicting that the bodily diagnoses or the bodily experiences that patients are actually reporting on, they're going to be attended to less for women compared to men, that sort of lack of being able to compensate for the actual attention. Now, when we look at just disparities that might be displayed in terms of ethnicity, we find a range of different evidence across different contexts in social life where people believe that white individuals and Black individuals are treated quite differently. So you'll see in terms of how people are dealing with police and how people are dealing with hiring and promotions, people believe that Black individuals are treated less fairly than white individuals. But what's really critical is when we look at just when seeking medical treatment, there's quite a bit of disparity, not just in the percentage of overall adults that believe that there is a difference in how Black versus white individuals treated. But if we take a look here in terms of one's own positionality as being someone who's Black or someone who's white, really does show a difference in how people believe they are treated by medicine as an institution. A critical, wonderful investigative journalists and also a ton of empirical pieces have documented that what's really critical about treating patients is believing them. And people of color quite often do not believe that they are believed by physicians. And it's a really horrible issue and an unjust issue that persists quite often in medicine. A really profound quote from this article from the Chicago Tribune was that if there was ever a book on medical racism, it should probably just be called "They Don't Believe Us." So the pain, the experiences that people of color quite often express, they tend to not be believed on average by physicians. So when we're looking at how people might actually attend to the sort of pain or experiences of people of color compared to white individuals, we're going to be looking at emotion markers, we're going to be looking at a range of other identifiers to see if there's a disparity in how people of color are treated compared to white individuals. Now, across both gender and ethnicity, a really critical marker that's also going to be investigated here is a category of terms that's called cognitive processing terms. Now, cognitive processing terms, essentially the shorthand way of thinking about this is words that reflect how someone might be working through an issue. So these are words such as should, would, ought. You can almost like see the mental gymnastics that people are going through when they would actually use words of this sort. People trying to essentially keep the mechanics going of trying to either resolve an issue or to work through exactly what is going on with a particular patient. And you'll see just from an ancillary example here by Siraj et al. In 2021, published in PNAS as well. These are data points from Reddit, actually, where time zero is when people experienced a breakup, a romantic breakup. You'll see when people are trying to work through their experience of why did this person dump me? How am I going to get through this experience? What actually went on here? Why did it lead to this this end of the relationship? Cognitive processing terms skyrocket. So working through the diagnoses or the experiences of a patient is something that is quite interesting and informative. How do physicians attend to and work through patients differently depending on the demographic makeup of the actual patient themselves? So with that sort of theoretical and empirical foundation set, what I'd like to do is to walk you through the sort of data that were collected and then get to the results. So there's a database called the Medical Information Marked of Intensive Care, or MIMIC database, produced by a bunch of MIT colleagues. And they have gone through the really painstaking process of creating a massive database. It's all available. It's not publicly available. You can essentially just apply for access through their program. You have to have special approvals and walking through sort of data access points. But essentially, when you sort of get through that barrier to entry, you can receive over data points on over 46,000 critical care patients, 58,000 hospital admissions, basically across a decade long. What's really critical is they also have a ton of different vital signs, a lot of medical information about each patient upon receiving a visit from a physician. And for me, what was really important was all these free text boxes that were provided so that physicians would write about how their patients are doing. And when you sort of collapse across all the different time points, 1.8 million caregiver notes were extracted from that one hospital in Boston, Massachusetts. And to comply with all the ethics and also the HIPAA compliance, these data were de-identified through not only automated means by removing names and removing specific identifiers, but humans also went in to ensure that there weren't any identifiers as well. So the lay of the land here is about 1.8 million caregiver notes across a decade long for a variety of different patients and medical cases from a single hospital. Now here's across the different 1.8 million caregiver notes, just basic descriptives. So we have a relatively even distribution across the 1.8 million in terms of those that originated from men versus women. And the majority, 70% of them, originated from white individuals compared to others of different ethnicities. So now that we sort of have like what data were collected, now how do I actually automatically, through natural language processing means, how do I take text and make it into numbers? How do I make language patterns something that is quantifiable? So let me give you an example of the types of language dimensions we often tend to look at. I'll use my alma mater as a sort of sentence for example. So let's say we take the sentence, Stanford has a beautiful campus. For those who have been on campus, I hope you would agree with that. There are two camps of words that we tend to look at in psychology of language scholarship. So we look at the content. So it's what people are talking about. These are nouns and verbs. It's like the meat and potatoes of a sentence. But another really important category of words are what are called style words. They describe how someone is communicating, the manner of which they are communicating. So these are words such as articles, prepositions, quantifiers. So if you were to ask a computer scientist in the 1960s or 1970s, What do you do with these style words, or also called stop words or junk words? Computer scientists would just say you throw them out. They're not telling you anything important about the language. But again, one of the really critical advancements from about the 1970s and 1980s was that these style words hold incredible value for who we are psychologically. They tell us information about depression. They tell us information about deception, information about personality. So if there are social or psychological processes that you are interested in identifying at the language level, style words are often the key indicators to indicate who we are, what we're thinking, and what we're feeling. And now the way to actually take those different camps of words and make them into numbers that we can analyze them quantitatively, we use a program that's called Linguistic Inquiry and Word Count, or LIWC, LIWC. Now, LIWC works on a dictionary-based program. So essentially, there are tons of human-validated dictionaries where humans have gone in and said, yes, these collections of words mean this higher order concept. So words like hate, aggression, bad, awful, they all mean negative things or negative emotions. So therefore, when you roll them up, we're trying to count the percentage of words that appear within each particular category. So let's take the example from before. Stanford has a beautiful campus. That's 5 words. That's going to be the denominator in all of our calculations. So that's WC. So Stanford is not an ordinary word in everyday common English, so it wouldn't be found in the LIWC dictionary, but has as an auxiliary verb 1/5 of the total word count, so 20%. And is an article, beautiful an adjective, and campus is a work-related term, so 20%. So the way we take text and make it into numbers is we're taking words and see if they're identified in a particular dictionary from this linguistic inquiry and word count tool, and then counting as a percent of the total word count. Therefore, we sort of control for really, really long texts, or we control for really short texts because we've accounted for a word count in the denominator. So just to remind us here, we're looking at emotion. So thinking about how physicians attend to the emotions of women compared to men and people of color compared to white individuals. A complementary idea is looking at where physicians are attending to the body and thinking about how physicians are attending to the actual diagnoses of patients, and then the degree to which physicians are working through these issues for critical care patients. So what I did was I ran a bunch of linear mixed models, controlling for the patient, the caregiver, the diagnosis, the hospital stay. All of these things I wanted to essentially account for is that we're really just looking at the links between language patterns and gender and ethnicity differences. So you'll see here, if we look at positive and negative emotion terms. So physicians attending to women tend to, on average, use more positive and negative emotion terms compared to physicians who are attending to men. So there is support for this first hypothesis, even though these effect sizes are fairly small. We find that there is a disparity in how women are attended to compared to men when they're in critical care. Just an excerpt sort of displaying these disparities. This is examples from the same diagnosis, the same physician, just different patients. You'll see here a white man was described with having incisional pain. They were grimacing, but the white woman, they were extremely anxious. They were crying. They didn't really know what was going on. They kept exclaiming, "Oh dear," repetitively. Much more negative, more emotional, focusing on the emotions of women more compared to men. And we're seeing this in the natural language that physicians are using when they're reporting on patients. Now, again, a complementary idea to that first hypothesis is that by attending more to the emotions of women compared to men, physicians are going to have less of attention to focus on the bodily diagnosis of women compared to men too. And we see that hypothesis also supported. So physicians attending to men used more body terms, words such as spine, face, neck, compared to physicians attending to women. And just an example here, again, everything's equivalent except for the actual demographics of the patient. And we see here that when physicians are attending to the man, there's one mention here of something that would be a body term, but no mention of any sort of body term for white women. Now, what we see in terms of how much are physicians working through the diagnoses of women compared to men, at least at the language level, we see that cognitive processing terms are elevated when physicians are attending to women compared to men. And I'll mention in a moment when we sort of go through all the ethnicity results, what I actually think is going on here under the hood is cognitive processing, or are these effects advocacy or unfamiliarity? That is actually an important open question, but we have some links to it, at least on the language level. Then when we just look at the ethnicity factor, and I want to also mention that in these linear mixed models, both gender and ethnicity were entered as simultaneous factors, so one controlling for the others, that we're really just isolating the effects of these factors alone. You'll see here that Black patients and Asian patients, physicians who are attending to them, physicians attended to their emotions less often compared to white patients. And what's really critical is that these results are supporting a host of evidence, not only from the psychological sciences, but also in medicine, where physicians are showing a disparity in how they are attending to patients of color compared to white patients. But here, the critical difference is that this is in the words, this is in the language patterns, compared to things that might be self-report or compared to experimental evidence. This is natural language, which is quite provocative, but also quite important when we think about the degree to which language really matters here. And if we focus just on one word in particular, a really important word in medicine, and not only that, the patient experience, pain. If we just look at the rate at which physicians are using the word pain when they look at patients of different demographics, you'll see that 22.6% of caregivers, of caregiver notes essentially mention the word pain for white patients, but a non-trivial decrease in the rate or the use of pain for Black patients and Asian patients. So when a range of different demographic groups suggest that they're not believed or their pain is not believed, we also see that in the language patterns. So physicians are using pain and pain-related words way less for Black and Asian patients compared to white individuals, also sort of corroborating and giving a lot of weight to a range of other evidence that preceded it. When we look at cognitive processing terms, physicians are working through and sort of cognitively and mechanically working through the diagnoses of Black and Asian patients more than white patients. And when we take all of the evidence together, the reduction in terms of the focus on emotions, and when we think about a range of all these other disparities, what I think, again, is going on here is not necessarily advocacy. So one argument could be, well, physicians are working through the diagnoses more, they're trying to fix the issue faster or more efficiently or better. But when we take all of this together, when we take all the evidence, I don't think it's necessarily an advocacy argument. I really think it's more of an unfamiliarity or a lack of knowledge about how to perhaps treat the patient best. There were gender and ethnicity interaction effects. So when we look at which group at the language level might be displaying the greatest disparity, or they might be showing the greatest rate of bias, we find that Black women are the group that is undermined the most by physicians, with Asian men also coming in terms of being second in terms of where the greatest disparities exist when we're looking at gender and ethnicity interactions. So why does this work matter? What I wanted to do is I wanted to sort of give a deep dive into sort of how to approach this idea of taking text and making it into numbers, revealing psychological effects such as bias, a really critical and important issue that has been for such a long time and remains one. Why does this work matter, not only potentially for an audience like this, where physicians are dealing with patients on an everyday basis, but then how does it also matter for patients? For physicians, I think this work matters not only because you're interacting with patients on on a daily basis, but because the acknowledgement that words matter is really critical. It seems like a fairly obvious step, but to understand the power of words and how attending to particular aspects of one's care can perhaps have downstream effects on patients, how they feel about you and how they feel about their care. That's all incredibly critical to acknowledge. It's also really critical to think about what safeguards or guardrails could there be in place to perhaps think about how we're conceptualizing and thinking about patients when they walk through the door looking for equitable and adequate care. Now, on the patient side, there's a really unjust and also horrible reality, again, that many patients face, which is called medical gaslighting. This idea that everything's got to be in the patient's head. They're either making it up, or they're just not really getting the issues, or things are not really, they're just not getting it, or it's all in their head. This evidence, what I really think it speaks to is that it's not all in the patient's head. When they feel like they are not being either respected, or when they feel like they are not being attended to properly, or they think that, well, if I was just a different person, then I wouldn't be treated this way. When we look across a decade long of data, 1.8 million different caregiver notes from a ton of different diagnoses, et cetera, these disparities, they're revealing that it's not just a disparity in one's head, it's a disparity in reality. It's a disparity in the actual language and in the actual experience that people are having. And I think acknowledging this, again, provides an opportunity for people to make changes in not only the way that they may be thinking about patients, but also structurally, what, again, perhaps either guardrails or institutional ways of course correcting could there perhaps be. So at least sort of summarizing here, and I want to leave a bunch of time for questions and comments. So I believe this work is really critical because it not only provides real world validation of prior either survey and experimental work, it provides that validation in a massive way, in massive scale, but it also shows that patients, when they're expressing themselves and feeling this particular way, it's also reflected in how patients or how physicians are attending to patients as well. So we see it on the other end. And what possible intervention opportunities are there? That's where the dialogue comes in. That's where I think social science and medicine really need to have greater conversations about what do we know from communication research? What do we know from the psychological sciences about how interventions can really be effective to not only give adequate care, but to give equitable care to patients? Because at the end of the day, I know that's what every person in this room wants to be doing, giving adequate, effective, equitable care to everyone. But we see that at the language level, sometimes that's just not, that's not what is actually what is occurring. So with that, I want to leave enough time for questions and leave enough time for conversation. I find that to be the most sometimes the most exciting parts of giving talks. So I want to thank you for your time, and I hope this has been informative. And I'm always open to collaboration opportunities. I think there's a wonderful blend between social science and medicine that the walls seem to be very high into making those collaborations work, but I don't think they actually are as high as they really are. So thank you for your time, and I'm really open for any questions you might have.
Dr. Markowitz, is it okay if I call you David? You can call me Umesh.
Yeah, Dave is perfect, or anything whatever you'd like.
Okay, perfect. Now, thank you for your time in bringing this fascinating, rarely viewed area of language analysis. I don't know how, I don't see any raised hands, so I'm just going to go ahead and ask a question. And for those of you who want to ask questions and I cannot see the raised hand, just put the question in the chat, then all of us can see it. So my dear friend,
Umesh, I will allow people. Janet has a raised hand after you're done, but if people raise their hands, I can allow them to ask the question.
Perfect. Perfect. Thank you, Evan. Then you run that part of it. I just have a question now.
Sure.
You know, this is very exciting. And I'm assuming that we are at the threshold of something. In other words, we are just starting off. So what are the pitfalls of what we are talking about here? What are some of the, this can't be all nice and rosy, right? There's got to be some pitfalls that we have to be worried about before we take this all at face value. Am I right, David?
Yeah, you're exactly right. So one of the first things to think about is what type of bias actually is this? So is it implicit bias? Is it explicit bias? I'm leaning towards, in terms of what the empirical evidence suggests, that this is more implicit than explicit, in the sense of, I think there are very few examples, I would imagine, where people are calling patients derogatory names, things like that. So one of the huge problems is, like, how does one course correct here? Or how do you form recommendations of how to course correct here? If course correct is even the right term to use. So that's one thing, is like, what type of bias is it? So you can't sweep with a very broad brush that all bias is the same. That's not the case. So how defining what this really is in terms of the type of bias is critical. But then when we're thinking about text in general, what is the predictive utility of using language to understand bias, either at the physician level or at the institutional level, right? So we don't know the degree to which language can actually predict the degree to which a physician might be more or less prone to bias. That is something for future work, right? We can build a bunch of classification tools to figure out specific people who might be prone to that, but you would imagine a host of false positives with that. And there are a ton of downstream consequences to red flagging someone perhaps as being more or less prone to bias. There are, I have a hard time thinking that a tool like that might exist in the same way as some of my work on deception and language works. I have a hard time thinking that a tool to pick out a liar versus a truth teller would work very well, just because we know that it's really difficult to do so. So there are a range of different sort of limitations or pitfalls with some of this work. But the thing that I want to sort of hit home here is we're just scratching the surface of just trying to understand how bias manifests at the language level, and acknowledging how language really, really matters. And I say that phrase not in a sort of not in sort of a crude way, in a way of suggesting that we all know that language matters, but the degree to which it matters for patients and their care, that's sort of like a bit of an open question. We need to do a ton of more research on, when I speak a certain way, are patients more or less likely to actually abide by their prescriptions, or more or less likely to abide by how often they go for scans? Or if I talk a specific way to a particular patient, are they more likely to delay a scan by a few weeks? All of these things are open questions, but to me, as a social scientist, they're inspiring.
We're going to have you back in a few years as this field blossoms and blooms to see where it's going. But this is fascinating work. Thank you, Evan, all yours.
Thank you.
So what I will allow Dr. Shapiro, who I have given talking privileges, to ask the next question. Thank you.
Oh, thank you, Evan. I think my hand was up by mistake, but I would just take the opportunity to say that this was so fascinating. And I think that, as you know, a clinician, I think it absolutely rings true what you're saying about how physicians think and how we write. And I think that, aside from learning from you and really thinking about it as a way to educate ourselves, do you see that there would be space to have some kind of, I don't know, flag censorship in medical records? Because I do think it's very disturbing, and it's very stigmatizing how these records are done. And I think it has consequences for patients, you know, when obviously for their health, but also how they're treated down the road.
I completely agree. And so one possibility is to not create a system that would red flag someone as being more or less prone to bias. But I think one way is to reconceptualize what the purpose and point of some of these free text or open text fields are when you're reporting on patients. So when I've given a few talks, I've given talks at Stanford Medical School, a range of other medical schools about this. And the number one question they say is, okay, well, how do we fix it? And one thing I thought about is not necessarily a fix, but it's a reconceptualization of what if we thought about these free text fields or thought of these ways of reporting on patients as Yelp reviews. Well, if you think about it like that, a Yelp review is public. It's something where it leaves a record of your experience, and it's something that others are going to use to then inform their own experience. Now, if you were to report on a patient knowing that all of this information, right, is not only available to other physicians, but your words are going to inform how others are going to be thinking and feeling about that patient, that's quite powerful, right? It's a reconfiguration of what the purpose of those particular systems actually are. It's not a closed book diary of how my patient is doing. It is a display of how I am thinking about that patient. And I think that sort of reconfiguration could actually be quite powerful. It's sometimes a small nudge that can go a really long distance.
I think also now that notes are able to be viewed by patients, you think that might make, people more considered in their writing.
Exactly right. I would imagine I've always wanted to, now that they are available to patients, I've always wanted to do a study pre and post that decision where you can imagine politeness rules and politeness communication tactics way up after things are public, which is, again, is not a bad thing. It's just a shift in communication norms based on the way that systems and structures are built.
Thank you.
I guess we're going to have to worry about the open mic effect. That something from personal, discussion may leak into the viewable by the patient.
Sure. I think there's a hand from Norma.
Yeah.
Yes, a couple of things. I think it's a fascinating problem. It's obviously to do with communications, but my concern is also body language.
Mm-hmm.
Before the groups, whether you're showing haste in being halfway out the door,
Right.
or expression on your face that is negative, sneering or frowning or looking like you're disbelieving the patient.
Yeah.
Of how that plays a role, that's really hard to get from the medical record, but it is maybe only done from video cameras that are now ubiquitous. Maybe we can see that.
Yeah, that is fascinating.
Medical leads. You're using medical leads, and patients always nod, but they had no idea what you said. And so that actually adds to it, because if the patient's educational background is limited, it's even harder for them to understand the words that are being said. So not only what's being said, how it's being said.
Exactly right, Norma. And I take it one step further. I don't even know if it has anything to do about patients' education. It has to do with just conventions within a community. So, for example, physicians talk very differently than non-physicians, even like doctors, other forms of doctors, right? So, for example, something being remarkable or unremarkable. Well, which one's good?
Right.
And for the average person, remarkable is pretty great, but we don't like that in medicine, right? So when something's remarkable, we need to remark on it, right? So medical jargon within a specific community can mean different things. And that's really, really critical to think about when we're talking about how to get there with patients, how to have them understand what physicians are saying. But to your former point about body language, it would be amazing if there were videotaped interactions between patients and physicians, again, so that patients and physicians, they agreed to being videotaped, et cetera. You can imagine an amazing study that paired language with also nonverbals and look to see what are those nonverbals, what's the body doing for patients that feel like they're not being heard, not only on the patient's side, but also the physician's side. You can imagine some really easy predictions of what are related to psychological distance. So if the patient feels like the physician's not really on my side or not really getting what I'm saying, they're going to stand further apart. They're going to be further apart versus someone who actually is closer together. Maybe that patient feels like they're being attended to better or more. So I love the questions and comments. This is the reason why I sort of said at the end.
I'd love some hints for how to talk with patients who are physicians, especially psychiatrists.
Sure.
That's, to me, the hardest group to talk with because they have their own very specific, I found, biases to start with, and also resistance to certain phrases or descriptions. I can give you lots of examples, and I felt it very, very challenging to try to deal with that.
Sure. No, that would be an opportunity to sort of go into that community and essentially figure out, well, when they have these good or bad experiences, like how do they talk about them? Simply asking people, how do they communicate those experiences? That could be an initial step, at least qualitatively, to think about what are the potential indicators there.
Okay, Dave, is there anyone else in the audience have any questions that they would like to ask? Please raise your hand and I'm happy to give people the opportunity. Otherwise, this was a great lecture that I think everyone really appreciated. And thank you so much.
Thank you for the time. I appreciate it.
Of course. Again, I just would like to remind everyone that there is the research meeting at 2 o'clock. Everyone should have a separate link in their Outlook calendar. So if you're able, please join.
Feel free to reach out with anyone if anyone has any other questions, or if you'd like to talk about research ideas. Always open to finding new colleagues and collaborators. So feel free to reach out.
We're going to take you up on that, Dave. Thank you so very much.
That'd be wonderful. Have a great day.